I just want to tell you how happy I am to be here. I don't know whether being 10 degrees is a reason not to come to class, but for those of you who aren't here, I guess we can find out. I really admire the fact that you're all here. As Ron said, I do a lot of HIV research, but I'm also an HIV clinician. I take care of patients in the clinic. Potentially next week, some of my patients will be here. I'm not sure who's coming. I'm intimidated by you guys, to be honest. Undergraduates make me nervous because you guys have a lot of power. But hopefully what will happen in the next hour or so will be enlightening for you and fun for me and fun for you. I think because it's such a big group, if you could save your questions to the end, but I'm happy to stay as long as you like to answer questions, and if the time's up, we can meet up there or down here if there are additional questions. I'm going to talk about some kind of basic biology, and I know like the range of experience in here is huge. I'm sure some of you are freshmen or sophomores and are interested in social scientists, and some of you are maybe on your way to get a master's or a PhD. So I will try to make it interesting for all of you, but as Dr. Strauss said, some of it may be over your head, some of it may be a little basic, but I think it'll all work. Can I ask, who here knows someone that has HIV or AIDS? Yeah. Okay. Yeah, I think that's really important. So all of us, I think, are touched in one way or another by HIV or AIDS. And I think the first question, before I talk about viruses or the immune system, I just want to remind you why this problem is so important. These are numbers that get updated every year. I think that you probably know a lot of this, but 35 million people live with HIV in the world. Unfortunately, despite knowing really just about all there is to know about how HIV is transmitted, about 2 million people get infected with HIV every year, and 1.5 million or something along those lines die of HIV every year. And in the United States, every year, pretty much consistently for the last 10 years, between 50 and 70,000 people get HIV. In North Carolina, it's about 1,000 to 1,500 people every year, despite the fact that we know how it's transmitted, we know how it's prevented. So it's obviously still a serious problem. You probably know that most of the HIV-infected people in the world live in southern Africa, but obviously they're all over the world. A trick question is, what country in the world has the most HIV? Any guesses? Which country has the most people, at least the second most people? India actually has the most HIV cases, probably followed by South Africa. But sooner or later, it'll be China, probably, just because there are so many people there. And HIV is basically almost everywhere. This is basically what I've already said. It's predominantly transmitted kind of worldwide through heterosexual sex, though obviously any kind of sex can transmit HIV. In the US, it began as an epidemic in men who have sex with men, and once again, it's now predominantly an epidemic of men who have sex with men, unfortunately, and it's mostly young men who have sex with men, and I'm sure you're going to hear about this as we go along over the next couple of months. And as I mentioned, the transmission in the US really hasn't changed very much. This is just a quick look at where the people live with HIV. South Africa has the majority of individuals, with Nigeria and India. And then the proportion of new cases of HIV, again, South Africa, Nigeria, Uganda, India, but again, mostly Southern Africa. That 4% for the US should be 2%. But obviously, Southern Africa is where we're. And to me, this is an old slide. This is over 10 years old. But for those of you who kind of deal in pictures, this is a population structure. The population structure for a normal population is supposed to kind of go up and then kind of gradually peak, right? In Southern Africa, unfortunately, it starts to thin out a lot earlier than it would here in the US, right? So in the US, those bars might not get smaller until maybe 60 or even 70 years old, because we have great life expectancy here. But what the blue bars show you is what is the projected population in the absence of effective therapy and the absence of effective prevention. And basically, you lose a substantial proportion of the population. And it's not just in the elderly. In fact, the elderly or the very old are kind of past their risk. But as you can see, starting around 25, 30, 35, 40, the population in a country, this is for Botswana, shrinks dramatically. And you know, I don't know how people feel about George Bush, but I think one of the most important things that his presidency did was the PEPFAR, which was the President's Emergency Relief for HIV. And part of it was because he and Colin Powell and others looked at how this might destabilize countries if we didn't really do something about it. If you lose more than half your population greater than 30 years old, it's obviously devastating. And this slide you can look at later on, but this is the risk of a boy in, I'm trying to remember the country now. Oh, in various countries, their risk of dying of AIDS. Not their risk of dying of AIDS if they have AIDS. It's their risk of dying of AIDS as opposed to dying of anything else. And in Botswana, at least at the time of this, their risk was 70% chance they would die of AIDS before they're ever even infected. And you can see, you know, different countries with different prevalences. It's not that bad now. I think with treatment it's very different. In a lot of these countries people are being treated. But it gives you an idea of the scope of the problem. And here's the US looking at HIV prevalence. And I just want you to focus on the bottom right part of our country. The darker the color, the higher the prevalence of HIV. And it's obvious you know, where the problem is and where we are. It's really a disease of the underprivileged. It's a disease of the poor in the South in particular, and also the metropolitan swath in the Northeast. And you can see that 300 and some of every 100,000 Americans actually have HIV, and that's why many of you raised your hand. So that's kind of the introduction, why this is important, why I think it's critical that everybody in this room learn something about HIV. And now we kind of get into the biology. And I think, to me, HIV, while being a kind of a terrible disease that has incredible, you know, worldwide consequences, it's also fascinating because HIV is a virus. Viruses are really small. I mean, really small. Our genome has 3.12 billion base pairs. For those of you who've taken biology, a base pair are, you know, Watson and Crick, that whole bit, you know, adenine, guanine. So with all our chromosomes, we have 3.12 billion base pairs. HIV has 9.2 thousand. So that's what the percentage is. Its genetic material is like a leaf in a you know, one page in a, you know, million-page book. It has so little genetic material. It's incredibly simple. It has just a few proteins. It's enveloped, meaning it has kind of an outer layer that is made of lipids or fats. And that's why, you know, if you had HIV on this countertop here, this desktop, and I came along, you know, after an hour or two and did this and touched my eye, nothing would happen to me because its envelope makes it kind of vulnerable to just drying or heat or Clorox or... and that's why you need kind of close contact, sex or birth or injection to transmit HIV. So the envelope actually is really important. And I'll talk about some of the other parts and try to make it sensible to you and not mysterious. It's got RNA. We have DNA. This virus is an RNA virus. It's important because it replicates different than our cells replicate. And that is both a problem and an opportunity. And when I talk to you the next time, sometime in February, I can talk about why it's opportunity. So I was trying to give you the idea of size here. I have to get out here to see this. So those are the viruses up on top. You can't actually see HIV with a regular microscope. You need a scanning electron microscope. And that's kind of what the virus looks like. The inside is that core of thick protein, and the outside is the envelope. This is a red blood cell. The red blood cell is essentially 75 times larger than HIV. And red blood cells are actually relatively small. And then if you put your pen down and dropped a blot of an ink tip on your paper, that would be your ink tip, and that would be the size of a red blood cell there. And HIV is 75 times smaller than that. So this kind of tiny thing with very little genetic material is capable of causing a worldwide pandemic and responsible for, literally millions of deaths each year. And you might think, well, shouldn't we be able to figure out how to stop it? Can't be that complicated, can it? Viruses need cells to live, like bacteria, like a strep throat or a skin infection or something like that. The bacteria can reproduce themselves. Viruses require a cell to live. HIV has to go through a cell to reproduce itself. And the reason why HIV is such a problem is because of the type of cell that it infects. So the critical part of HIV is that it only infects a certain type of cell. This cell has a molecule on the surface. It's called the CD4 molecule. And HIV can only bind to that molecule. It's really not important what CD4 does. But what's important is what cells have CD4 on the surface. And the main cell in your immune system, kind of the central cell that kind of, if you think of it as a conductor in an orchestra, the CD4 cell is the conductor, right? It's what kind of tells the various other parts of the immune system when to come in, when to be quiet, when to amplify. And HIV infects that cell. If HIV infected a different cell, it would be a different disease and potentially not as devastating. But it is because it infects the CD4 cell that makes HIV the disease that it is. Because over time, it essentially erodes our immune system to the point where we can't control things that are really relatively simple normally for our body to control. It's also useful to know that HIV can't only get into a CD4 cell by attaching to that molecule. It has to have a second receptor. Scientists for a long time knew that, for example, you can put human CD4 molecules on mouse cells, for example, but they could never get HIV to infect a mouse cell that had human CD4 on the surface. And it turns out there's a second receptor that's required. So it's a two-step process. Again, the reason that's important is it turns out some people, and I'll show you in a minute, don't always have that second receptor on the surface of their cells. And those relatively uncommon people are actually relatively resistant to HIV. So this is the surface of the cell. It's a picture, obviously. I don't know if it really looks like that, but it kind of looks to me like a lunar landscape or something. And on the surface of the cell, the CD4 cell are these CD4 molecules. Then there's that second receptor that looks kind of like the Loch Ness Monster, kind of zigzagging through the surface of the cell. And what happens is HIV has to contact the CD4 molecule in a very specific way. The virus has to kind of touch down on the CD4 cell, the CD4 molecule, in a very specific way. It can't just kind of glom onto it. It has to, there's a specific part of the virus that is the receptor for the CD4 molecule. And again, you would think, oh, okay, well, why don't we just block that? That should be pretty straightforward. Why can't we just do that? And we've tried, and we may have some success, but unfortunately, the virus is able to escape and avoid our body's ability to protect and medication's ability to block the virus. So this kind of sits down like a lunar landing module, and then it has to contact this second receptor. And when it does that, it changes its shape. The surface of the virus changes its shape, and those things that look like maybe like a drill, those are the fusion molecules, and it's just like a machine. It's just a teeny, tiny machine. Are there any engineers in here? People want to be engineers? There we go. It is really a machine, honestly, but it's a tiny machine. And those spikes actually stick into the surface of the cell, and after that happens, it gets pulled down, and what happens is the two surfaces, the virus surface and the cell surface, come close together. And since those are kind of fat and lipids, it's like two bubbles, soap bubbles, like in the bathtub. Like what happens when two bubbles get near each other? They fuse, right? So the virus fuses with the cell, and it enters the cell. And that's how HIV infects. And if you remember one thing about this, it's because it infects this CD4 lymphocyte, the conductor of our immune system, is why HIV is a devastating disease. So the next step in the virus life cycle, so for all of us to reproduce, we have to copy our genetic material. And so I mentioned to you that the virus's genetic material is RNA, but in order to to fully infect the cell, the RNA has to come in to become DNA, because that's what our message is. That's what our blueprint is. It's DNA. And that, if this works, happens by a process called reverse transcription. We don't have this process in our body. We don't reverse transcribe anything. We do the other way. We go from DNA to RNA, but the virus goes from RNA to DNA. And that's important because when I talk to you in a month or so, our first inhibitors, our first drugs that worked to stop the virus, actually block this enzyme. And we can block this enzyme pretty effectively because our bodies don't use an enzyme like this. And it turns out that in someone who's infected, at least most 99% of people that are infected, the virus rapidly replicates. In a person who's infected, even if they're completely asymptomatic, and people with HIV can have no symptoms for years, while their immune system is busily being kind of destroyed bit by bit. Those people can produce anywhere from 100 million to 1 billion viruses every day. And this reverse transcriptase, that's what RT stands for, this enzyme that takes RNA to DNA, actually makes an error about every time it replicates. And you might think that's a pretty bad strategy. Like if humans had a mutation or an error every time we had an offspring, that would be a problem. But for the virus, it turns out it's not a problem, it's an advantage. Because so many particles are made that while it's making these errors, some of those errors actually lead to changes in the virus that allow it to escape from our immune system. So there are viruses that are somewhat like HIV that don't replicate as rapidly, and they tend not to be as dangerous, not to be as what we call pathogenic, causing disease. So this viral replication rate leads to mutations that lead to an inability for our immune systems to kind of contain the virus. And that's another really important concept. And that's why I started doing this work in kind of the mid-1980s, probably. Is anybody born after 1985? Ron, don't raise your hand. Yeah, so, I mean, we've been doing this a long time. And I think, and Ron, you can verify this, I think about every 2 years or so, somebody who's developing an HIV vaccine says, we'll have an HIV vaccine in 5 to 10 years. And they've said that every 5 to 10 years for a long time. And we don't have an HIV vaccine. And while we're closer, we're not that close. And it's because the virus keeps changing with time. So this is a picture. I might have to point to this. So who had the flu this year? Anybody have the flu yet? I did. Oh, wow, this is great. Only a couple. So how often do you get a flu shot? Who knows? if you want to prevent the flu? Every year, right? And why do you need a flu shot every year? Because the virus is variable. It changes year to year. In fact, this year's flu vaccine is only about 60% effective, because I got the flu vaccine and I still got the flu. So if this dot here is the genetic diversity of flu, right? So if you just look at the blueprints of the flu virus and you just get, a couple of thousand of them and see how different they are one from the other, and this dot represents the range of difference. So this little tiny dot up here on the left, as you look at it, that's the diversity of influenza for an entire year in 1997 to 1998. This is the diversity of HIV, meaning how different are all these different HIV blueprints within one person. And this is just one part of the virus. And remember, the virus isn't that big. That's a diversity in one individual at one point in time. Because as the virus replicates within any person, the virus becomes more and more diverse. Its genetic material kind of diversifies. And by diversifying, it can escape from the immune system. And then if you look at remember, here's influenza. Whoops. Oh, I messed up. This is influenza, right, for a whole year, where you have to get vaccinated every year. And here's the diversity in 23 individuals over a couple of years in Amsterdam. Here's the global epidemic of influenza in 1996, 90 different samples. And here's all of HIV, the diversity of HIV in 1997 in the DRC, the Democratic Republic of the Congo. HIV is incredibly diverse because as it replicates, it becomes different. I'm going to skip this stuff because I think it's not quite as important. So HIV enters CD4 cells. HIV replicates by having RNA go to DNA, and it makes a lot of mistakes, but some of the mistakes or errors give the virus an advantage. And then the other critical point is, in order for HIV to replicate, it has to actually integrate into the DNA of the person it's infecting. So it has to get inside the genetic material of the person that it's infecting. So within the CD4 cells that are being infected and someone with HIV, HIV actually integrates. It has to get in there. If it doesn't integrate, it can't replicate. And this is critical because the other thing we'd like to do is cure people with HIV. But the problem is HIV kind of integrates itself into the chromosomes, our host DNA. And obviously that's a problem because how does one get it out? How does one find it? And it integrates. I'm just going to quickly flip through this. It's a clever virus. It uses an enzyme called an integrase, which is a pretty good name for something that's integrating. And it chops a little hole in the person's DNA, and the virus DNA, because remember, it went from RNA to DNA, the virus DNA inserts itself, and then our body, our cells, they don't like little nicks and cuts in our DNA. We don't like there to be any problems, any mistakes. So our enzymes, polymerases, actually come by and smooth the whole thing out and make sure that the HIV DNA is tucked in there nice and tight with no mistakes. And that's what it looks like. And then finally, there are a lot of other steps, and I'm not going to bother you with them. For the virus to replicate, that DNA has to make more RNA, which is going to be the genetic material for the progeny, the daughter viruses that come out. And this RNA becomes protein. The protein assembles, and it actually self-assembles, which is kind of an interesting concept. I'd like to cut up a bunch of wood in my garage and have it self-assemble like into a table or something. But it won't do that for me. I've tried. So it self-assembles, and only when the virus is this kind of tight little particle, like right here, is the virus infectious. So that's kind of the life cycle. That's what's going on in one cell. Well, what's going on in one individual? So that was what's going on in one cell. What's going on in one individual, I've already mentioned to you. The virus is replicating at a very high rate. CD4 cells that are activated kind of, in the body, kind of defending the body, they become activated. And HIV loves activated cells because it can replicate really quickly. And actually, it doesn't take long. HIV can infect and replicate within about a day and a half within these cells and produce more virus, and these cells die. And that's most of what's going on. And if that was all that was going on, that HIV was just replicating, if we could stop that replication, we could cure HIV. But unfortunately, HIV also does this. There are HIV-infected, there are CD4 cells that are much quieter. They're latent. The CD4 cell, like I said, is the conductor, but it's also supposed to remember. So you got a vaccine when you were 15 months old for measles or mumps or rubella. And that's because next year or 2 years from now, when you go to Central America and you volunteer and you take care of infants in Guatemala, and the infant has measles, mumps, or rubella, you don't get sick because you have CD4 cells and other immune cells that remember that you were vaccinated. So their goal is to live a long time, right? Those cells are supposed to live a long time. So unfortunately, what happens occasionally, HIV will get into one of these cells that either is already latent or resting, or maybe one of these cells that's partially activated becomes latent or becomes a resting cell. And then HIV inside one of these resting cells can live for a very, very long time because those cells are designed to live for a very long time. And this is HIV latency. And while I'm not going to talk about it today, but will later, we actually have treatment now that's effective, very effective. And we can shut down HIV replication. We can shut down that process that was on the left side of the slide. And we can make people with HIV feel healthy. And we think, almost normalize their immune system so that their CD4 cell count becomes normal. But the problem is we have those cells that are designed to remember. They're designed to persist for a long time. Those cells are meant to renew themselves and remember that you got that. This is your measles vaccine here when you were 15 months. And here's the kid that sneezes on you or spits in your eye when you're down in Guatemala. And you get that antigen, and your body remembers, and you clear that, and you don't get the measles. But what happens when HIV infects someone is some of these cells get infected with HIV and they die. But occasionally, one out of 1 million cells, or it's a very low number, gets HIV into that host DNA, and the cell goes back to sleep. And it can persist for years. In fact, it's estimated that even if we could stop HIV replication completely, just stop it from replicating, and wait for those cells that are infected but not replicating to die, if you only had 1 million cells in your body that were HIV infected, it would take about 70 years for those cells to all die. So we're not going to cure HIV by just treating someone with what we have now and watching what happens. So now we go to like a population. So how is HIV transmitted? This slide, I think, is pretty good. Sex is the most common way by far that HIV is transmitted. Men can transmit to women. Women can transmit to men. Men can transmit to men. It's anal sex that's the most efficient sexual method, or sexual behavior, sorry, that leads to transmission. So it doesn't matter if a man is having sex with a man and having anal sex, or a man is having sex with a woman and having anal sex. It's very efficient. And there are, the number of women that actually have, the proportion of women, especially in some populations that have anal sex, is not maybe 0 or 0.1%. Sometimes in surveys it can be as high as 2 to 5%. So transmission happens. Female to female transmission is pretty unlikely, but I suppose it can happen. And I think the one thing that's not completely clear is can you transmit HIV via oral sex? The answer to that is typically yes, you can, because if you ask someone who comes in and they're HIV infected, if you ask enough people, they'll say to you, the only sex I ever have is oral sex, and now I have HIV. Nobody's watching them 24/7. No one knows for sure that the only type of sex they have is oral sex. If I got HIV infected and was embarrassed, I might say that that's the only type of sex I have. But we believe that oral sex can transmit HIV, but probably at an incredibly low rate. Then the other most common way worldwide is maternal fetal transmission. And so that means from a mother to either her fetus or her infant that's being born, or her baby as the baby is breastfeeding. And the thing that's remarkable about the human placenta is that even a woman who is not being treated for HIV, that has thousands of virus particles circulating in her blood all day long, the rate of transmission is only about 30%. So the human placenta is a pretty remarkable thing. But unfortunately, without treatment, the transmission rate is about 30% from mother to fetus or mother to infant. And then finally, parenteral, which basically means injection, drug use, needle stick, blood transfusion. And probably you know that, and it's a great story actually. Great. It's a sad story that many young men, hemophiliacs, were infected with HIV in the 1980s. And there's some sense that some people actually knew what was going on and knew about the potential risk for transmission, and the speed at which the blood supply, at least for hemophiliacs, became safe was perhaps a little slower than could have happened. These are some of the risks. I'm not going to walk through them, but transmission is not that efficient. It may be from sex from an infected woman to a man, maybe. I'm embarrassed to put this up because Kim is sitting here. She knows more about this much more than I do. In fact, I'll just go to, I think this is your paper, yes? Yeah, this is Kim's paper. Kind of estimating the transmissions per contact. So for kind of anal sex, she estimated that for every 1,000 contacts, the risk was about 3% or so, or 30 out of 1,000. And if you have a STI stands for sexually transmitted infection, that increases your risk. And men who are circumcised are a little bit less likely, or are substantially less likely to transmit or to become infected than men who are uncircumcised. This number down here is not the number of patients that were studied, or it's the number of studies that were evaluated, right, Kim? Okay. And if I've kind of altered this anyway, just don't tell anybody. So what about pathogenesis? So how does HIV cause disease? And I talk a lot, so I got to be careful. You can break HIV infection kind of into two parts. The first part is called acute HIV infection. So in other words, if a person has sex with an infected person and gets exposed to the virus, approximately 2 weeks later, they'll actually become ill. Most people become ill. Maybe about 70 or 80% will have some symptoms. Fever, sometimes swollen glands, maybe a rash, maybe they'll feel run down. They'll have a viral syndrome. And they do have a viral syndrome. Unfortunately, it's not like a cold. It's HIV. Some people can actually become very sick during that period, that first couple of weeks to a couple of months. And And it's a period where your immune system isn't ready for HIV at all. So the virus replicates at a very high level. And like I said, some people can become quite sick and even get hospitalized at that time. But then the body's immune system does respond, and I'll talk about that in a little bit. And the infection kind of moves into a more chronic phase. And this chronic phase is actually begins with what people call a clinically latent period. And that, I think, is a kind of a misnomer in that the virus itself is replicating. And like I said, about 99% of people, the virus is replicating at a relatively high level. But for the most part, people have very few symptoms. In fact, the time from infection to an actual AIDS symptom, like a serious infection that people with a healthy immune system wouldn't normally get, the average time is actually 10 years. That's a problem because that person is infectious for all those 10 years. And if they don't get an HIV test, they don't get diagnosed, they may not know that they're infected. And therefore, they continue to transmit the virus. So there's a chronic acute phase that's short and a chronic phase that can be very long. And again, that's a pretty simple concept, but one that's worth remembering. Unfortunately, HIV can enter and attack all different kind of compartments in our body. So I mentioned CD4 lymphocytes, the conductor of the immune system, has CD4 on the surface. There are some other cells that also have CD4 on the surface, including cells that are in our tissue, like our liver and lungs, and also cells that are in and around our brain. Not neurons, not the neuronal cells, but cells in. And Chris Pilcher, who worked with us for a long time, showed that within a few days of the virus starting to replicate, the virus enters all these different tissues, the brain, the tissue around the intestinal tract, lymph nodes, the glands that get swollen when you have strep throat. And it enters the genitourinary tract, the vagina, the testicles, the semen. And so probably within days or a week or two from when you're exposed, you actually become infectious. And because virus levels are so high, you can actually be very infectious. If this were a medical school class, so I'm focusing it on these guys over here, I always ask, what's the biggest immune organ that you have in your body? And the medical students always say, probably not this guy because I know him, he's really smart. They say like the spleen or something like that. It's actually not the spleen, it's your intestinal tract, which starts here and ends there. And if you think about it, where is your body exposed to the most outside world? Lungs is a good one, you breathe in and out. But, as a kid, you eat dirt and stuff like that. And you put things in your mouth that you maybe shouldn't. Maybe it's on the food, maybe it's in other things. So your immune system in your gut is really very, very active. It's being exposed to foreign molecules or something called antigens really daily. And so when someone gets infected with HIV, the area in their body that really replicates the virus at a very high level is the immune system around the intestinal tract. And I got a bunch of slides on this. I'm going to kind of skip it because it's not all that important. But it is an area of our body that's very immunologically active. Remember, acute infection, very high level of virus. A lot of immune cell destruction happens very early. If I go backwards, we used to think like this on the top right here. We used to think that when someone gets acute HIV infection, they lose some CD4 cells in their blood, but they come back, and then it takes 10, 15, 20 years to really become sick. What we now know is actually in that first couple of months, people lose a substantial part of their immune system because there's so much virus replication that's occurring because the immune system hasn't got on board yet. So the other thing that would make sense, right, if you have a very high level of virus that's replicating and you have very little immune response, you're probably super infectious. And many people think, and I think it's probably true, that a lot of the spread of HIV, one reason why we still have 50 or 60,000 new infections every year, is because the people that are spreading HIV are people that are really recently infected and are therefore not in care, not on treatment, not thinking about prevention. In fact, they're doing stuff like having sex with many different people or sharing needles. They have a behavior, which you'll hear a ton about over the next couple months, that is actually likely to transmit HIV. So there's a lot of transmission during acute infection. So what about the host? So I've talked about the virus. For the last 15 minutes or so, I'll talk about the host. So what do we do to defend ourselves against HIV? If we didn't have an immune response, if we didn't defend ourselves, then people would get HIV, the virus would replicate, the CD4 cells would get depleted, and we'd probably die over 3 to 6 months. In fact, they've taken monkeys, animals, and there's a very similar infection in animals called SIV, simian immune deficiency virus. And they've actually exposed animals to SIV, and before they exposed them, they depleted some of the body defense cells. And it was very clear that if you depleted a certain type of body defense cell, what's called a killer cell, a CD8 effector cell, which is there on the bottom, or almost on the bottom, those animals progressed rapidly to kind of simian or monkey AIDS and would die. And our bodies have several layers of defense. The simplest layer of defense is something like our skin. Our skin is thick. You could rub HIV on your skin for hours probably, and you wouldn't become infected. Not that you would do that, but you couldn't. And in fact, the reason why vaginal sex is less risky than anal sex is the lining of the vagina is much thicker, and it protects women. The lining of the rectum or anus is much, much thinner, and therefore it's not as protective. Then our body also has what are called innate defenses. That means defenses that have probably been with us, since we were swimming around in the primordial soup. Things that it doesn't require any sophisticated molecules. I mean, those of you who are biologists and know a lot about cytokines and chemokines and immune responses, innate defenses are simple, but they're pretty effective, actually, and protect us from lots of things, viruses and other things in the environment. But the thing that probably protects us the most are specific immune responses. And again, if you take anything out of here, there are a couple of points to take out, is we have two basic type of immune responses. We have antibodies, which are molecules. And when people think about vaccination, they think about building up antibodies. And then there's cell-mediated immunity, which are cells that are specifically targeted to protect us from certain pathogens or even our immune system can protect us from other things like cancer, in fact. So simplest is stuff like the skin. Then innate defenses are pretty simple, been around for millions of years probably. And then HIV specific responses, like your flu vaccine creates a specific flu response. A measles vaccine creates a specific measles response. And if we had an HIV vaccine, we'd want it to create an HIV-specific response. So as it turns out, some of these simple defenses, if you think of a defense, and scientists have been thinking about defenses, innate defenses, for a long time, HIV has figured out a way to get around it. For example, in our body, for example, if I tried to infect you with simian immune deficiency virus, I couldn't. Because in your body, there's something called TRIM5. TRIM5 is just a little protein that runs around in your cells. But if it sees a virus capsule in the inside the cell, it coats it around the virus capsule and brings it into essentially this big garbage disposal called the ubiquitination. It actually, one way or the other, it leads to destruction of that capsid and no infection, which is great, except for HIV makes a protein, little tiny protein, called VPR, that actually blocks TRIM5 alpha, so that doesn't protect us against HIV. It protects us against, mouse retroviruses and monkey retroviruses, but HIV figured a way around it. Then, did I go backwards? Oh, sorry, I'll go forward. Then we actually have a molecule in our bodies that essentially kind of totally messes with the genetic code of viruses. It's like it took a blueprint and put just hundreds of errors in that blueprint. This thing is called ApoBec. It's not that important how it does it. But it protects us against lots of viruses, except HIV has this little tiny protein called VIF. And VIF blocks this ApoBec. So HIV gets around this mechanism for protecting us from viruses. And finally, and there are others too, these are just examples. Many viruses have to be released from a cell, right? It has to release from a cell to go on to a new cell and cause more infection. And in our bodies, we have this molecule, protects us. It's not an immune molecule, it's innate, called tetherin, that actually attaches to these viruses, and they're stuck on the cell. So this picture up here is a HIV infection where tetherin is working. And you can see the virus can't get off the cell. It's stuck. And the immune system would come by and clean this up. But HIV makes this little protein that blocks tetherin so that we're no longer protected from HIV. So our innate defenses, HIV's gotten around those. So what we need, and this is the other example I wanted to make before I get into specific defenses, which is, I mentioned that second receptor. So HIV binds to CD4, and then it has to bind to that serpent-looking thing, the CCR5 or CXCR4 molecule. Well, it turns out about 1 out of every 200 people, Caucasians, actually don't make CCR5. So there are probably 2 people, maybe 3 people in this room that actually don't make CCR5. And HIV has a very hard time infecting those people. Sometimes the virus can use this other receptor, but it prefers most of the time to use CCR5. So there's a small population of people that actually are protected from HIV because they don't have this second receptor. And it's interesting, why are people like this? Why does their immune system still work when it's missing this molecule that might be important? And we learned a lot about HIV because of this genetic defect. So this is our immune system. The CD4 cell is central to the immune system. You have cell-mediated on this side. You have antibodies on this side. And when someone becomes infected, our immune system does respond. It does respond. And if it didn't respond, then people would progress incredibly rapidly. But they don't, because the immune system does respond. So what happens is the body first makes antibody. But remember that virus is making errors. So it turns out those antibodies don't bind very well because the virus continues to change. And then the cells, the cell-mediated part, those cytotoxic T cells, those killer cells, those CD8 cells, it's all the same name. The body makes these T cells that are informed by the CD4 cell. The CD4 helps build that response. And what happens is, when that response comes up, so on the top is the virus level that goes up to maybe 1 million or 10 million in someone that has HIV infection, and they're in that acute period. But what happens is our body does respond. We make these cytotoxic cells that actually control the virus. The problem is they can't fully control the virus. They only partially control the virus, and the virus persists over time. Eventually, we make better antibodies called neutralizing antibodies. But the problem with those neutralizing antibodies is the neutralizing antibodies you make in May are really good at neutralizing the viruses from February, but they stink at neutralizing the HIV viruses in your body from May. And then if you look at the neutralizing antibodies that show up in August, they're really good at neutralizing the virus that is in the body from May. But because the virus continues to evolve, not big evolution, little evolution, the neutralizing antibodies are not as effective. And one of the holy grails is finding what are called broadly neutralizing antibodies, antibodies that can neutralize all different strains of the HIV virus. And hopefully someday that'll be the source of a HIV vaccine. So just to finish up in the last little bit, HIV pathogenesis and chronic infection, it's very variable. Some people progress in just a few years from infection to AIDS and even death. Other people have been infected for 20 years, 25 years. In fact, there's a guy that I saw today in the hospital. He's probably been infected for 15 years, and his CD4 cell count is completely normal still. And there are a lot of things that affect that. One of them is the virus. Some viruses are some HIV are more pathogenic, more destructive than others. But really the main thing is the immune system. Some people's immune systems are more effective at controlling the virus than other people. And in fact, now I guess you can put a little thing on the inside of your cheek, put it in an envelope, send it somewhere, and you can get your genome, your human genome, right? Or I don't know whether it's a full-length genome or GWAS, probably GWAS, yeah. It turns out, obviously, we all are genetically pretty variable. That's why we all don't look the same or think the same or smell the same. Well, it turns out people have looked at the human genome and said, what part of the human genome dictates protection? What part of the human genome dictates slow progression? And this next thing here, oh, it's a little bit out of order. Shoot. This next thing here is what's called a Manhattan plot. These are all our chromosomes. This is probably a GWAS, meaning they're looking at little markers within the human genome. And this is a p-value. Some people here are scientists, right? A p of 0.05 is significant. Well, when you're looking at a genome and you're making literally thousands of comparisons, this is the log of the p-value. So it's 10 to the minus 20. That's a p-value that's got, I think, 20 zeros in front of it or something like that. And all of the gene markers that are shown to protect against HIV are all in one gene. They're all stacked up in one gene. And that's the gene that dictates your HLA type, which is one of the signatures of your immune system. So protection against HIV progression, how quickly someone progresses from infection to a serious AIDS event, HIV infection to a serious AIDS event, is really dictated by how well your immune system can respond. And we know that certain HLA types, again, if you needed a bone marrow transplant, you would get an HLA type so someone would match with you, right? So your immune system wouldn't reject that person. So we know that certain HLA types, it's just a number, B27, B57, are pretty protective. And others are bad. They're not very protective at all. So it turns out that if you look at a person that has HIV, you can measure how much virus they have in their blood. The patients call it their viral load. Maybe next week they'll talk about what their viral load is. And hopefully a lot of them will say, my viral load's not detectable because they're on treatment and their virus level is suppressed. But before treatment, some patients may have a virus level of 1,000. And that's because they're lucky enough to have a pretty effective immune response. And those people that have a viral load of 1,000, if you followed them, this again is without treatment, if you follow them for 5 years, the likelihood that they'll develop AIDS is less than 1 out of 10. On the other hand, somebody else that has HIV infection might have a virus level of 1 million. And next week you could ask them. They'll know. You can ask them, what was your highest virus level? And many of them will know. And the person that has a virus level of 1 million, again, if you followed a bunch of people with virus levels of 1 million, within 5 years, about 2/3 of them will have developed AIDS in the absence of treatment. In the presence of treatment, it's all different, but in the absence, it's quite different. So I'm mentioning that the important immune response is this T cell, this killer CD8 positive cell. CD8 is another molecule that goes on the surface. HIV cannot infect CD8 cells, but they actually can destroy HIV-infected cells, so they're part of our body's defense. And I mentioned about neutralizing antibodies, and at some point, perhaps, we'll be able to create a vaccine that can produce broadly neutralizing antibodies that will actually protect people from HIV infection. So I'm going to just get to almost to the end here. And I'll talk a lot about this in a month or so. What happens over time is that the HIV is constantly infecting CD4 cells. And our body can make more CD4 cells. And the younger you are, the greater capacity you have to produce CD4 cells. In fact, in a very simple study in hemophiliacs that was done in the late 80s and early 90s, they just looked at the likelihood of death of someone who got HIV, and they could time it because the HIV got into the blood supply at around a specific time. They found that one of the most protective factors was just the age. The younger you were, the less likely you were to have your HIV progress, and probably because your body was better capable of producing CD4 cells. And it was better to be 15 than it was to be 20. It was better to be 20 than it was to be 25, et cetera. But what happens over time is HIV gradually wears down the immune system, and infections, like serious infections like tuberculosis or pneumonia, bacterial pneumonia, can occur at any time. But over time, as you lose CD4 cells, it's like taking strings out of a net. Our immune system is like a net kind of protecting us. And as you pull the strings out of the net, things that normally would never get through the net, some of these things down at the bottom, like toxo, probably half of you in this room have been exposed to toxoplasmosis, and you probably have a little bit of toxo in your body somewhere. Don't worry about it. If you were from France, about 90%, because they eat raw meat in France apparently, have toxo in their body. And it doesn't matter because your body defends you against it. But as those strings get pulled out of the net, your body has a harder time defending even against things that normally don't cause much disease. And I'll talk about that more in a month. So the end result over time is progression of HIV, loss of CD4 cells, and the emergence of infections, cancers, and other clinical syndromes that give you the diagnosis of AIDS. So there, I'm done. Close.
That's a lot of information.
Yeah, really.
So masterful job of lots of information, but in the spirit of hearing your questions, we save some time. There'll be a code to go up on the screen in just a moment.
Yeah.
Go ahead and
don't
send
leave.
the email.
Someone ask a question. Make me feel better.
Yeah, let's. Here's a question up front. I'll repeat it.
So you mentioned that HIV integrates itself with your DNA. Does it always integrate itself in the same place?
So HIV integrates into your DNA. Does it always integrate into the same place?
Unfortunately, no. There are some viruses that do specifically integrate in specific kind of hotspots, and there are probably some areas that are kind of more active in terms of gene expression where HIV is more likely to integrate, but unfortunately, no. So it leads to the conundrum, how do we get it out? But it's a good question. Great.
Question.
Yeah, in the middle there.
Okay.
Yeah, great question.
So let's
Go ahead.
repeat it. When the integration happens, does it happen in specific places, or is it just anywhere?
Yeah, so the question is, could this integration disrupt a gene? It certainly could, and it may in some cells. We're learning a lot more about this actually recently, because it turns out when you suppress patients on therapy, there's still some virus released, and it turns out people who are very clever can actually look to see where that virus has been integrated. So there are some active genes where HIV preferentially enters, but it's not that there's a specific integration site. But I'm sure it does disrupt some genes, absolutely. But it probably does integrate into active gene regions as opposed to the nonsense areas.
Okay, there was a question up here. Yes.
Yep.
But also, if I'm not mistaken, symptoms are very cold or flu-like. So it's very possible that the person could be infected, treat the symptoms like they would treat a cold, but still, they don't really know the HIV positive, correct?
So this is about the acute infection, and could people be treating it as though it was the flu or a cold?
Absolutely, 100%. In fact, there was a guy actually who was a UNC undergraduate, and then a UNC medical student, and then a UNC resident, and he went on to Harvard. And he actually started seeing young men at Mass General in Boston who came in with what they thought was mono. And it's a very mono-like symptom. You get swollen glands, you're kind of tired. And he was one of the first people to very carefully describe this acute infection period, which normally resolves on its own, but it's very nonspecific. I can tell you, we study acute infection here in North Carolina, and the most common diagnosis our patients get when they go to an emergency room is Rocky Mountain spotted fever, because that's a common febrile infection that doctors worry about. So it's mistaken. Go ahead.
So you had another question.
And this is regarding the reverse transcription. You're saying that basically the only way for HIV to replicate in the body is to have to start the reverse transcription. And this might be a question that maybe I should hold off the pharmacy, but I was trying to understand with PrEP medication, like what exactly is PrEP medication doing? Is it a prevent transcription or?
Okay, he's asking about pre-exposure prophylaxis. We're going to learn a lot more about that. So we're going to put that question on the hold. You bring it back, because we're going to have people here who are going to spend a lot more time on that. I actually am going to call this to a close. Okay. I want to thank Dr. Eron, and I want to remind you, don't freak out. This was throwing a lot of new terms and a lot of new concepts at you. We're going to come back, and it's not going to mostly be about the biology. Thank you so much.
Hey.
Joe.